Hi, I'm Stephen Duckett, Director of the Health Program at Grattan Institute. What I'm trying to do today in this brief video is to explain the complexity of hospital funding in Australia and some of the options that are floating around. So what I want to start with is explaining how the flow of funds for hospital care works now. All of the money to fund hospitals, be they public or private, comes from households. Some comes via Commonwealth taxpayers, some comes via state taxpayers, and some comes directly out of a patient's own pockets. So, if we look at public hospitals to start with, we spend a bit more than $50 billion a year on public hospitals. About $30 billion comes from state taxpayers to the health department to the public hospitals. The Commonwealth has a matching formula, and about $21 billion or so comes from Commonwealth taxpayers to the state health department to the public hospitals. There's also a flow of funds from health insurance because there are private patients in public hospitals as well, and there's also a flow of money from patient out-of-pockets. On the private hospital side, things are a bit more complicated. Most of the money for private hospitals comes from private health insurance, and the Commonwealth supports private health insurance. Commonwealth taxpayers put in about a bit more than $3 billion a year into health insurers through the private health insurance rebate. In addition, there's about $9 billion a year that flows from patient out-of-pockets directly to private hospitals. And so in all, there's a bit more than around $25 billion a year that's the cost of private hospitals. I now want to talk about two of the options that are floating around. The first is Medicare Select, which was floated, not recommended, floated by the National Health and Hospitals Reform Commission back in 2009. The idea here is that there are too many different funding sources. We want to get rid of Commonwealth State. We want to somehow put it all together in a single pool. But putting into a single pool means essentially giving it to private health insurance. And so what you do is you select your private health insurer, and they would look after all of the money that used to flow from state taxpayers, the money that used to flow from Commonwealth taxpayers to public and private hospitals, and there'd be a single pool. The health insurer would then fund public and private hospitals. The problem with this is the administrative costs of private health insurers are way bigger than the administrative costs in the public system. This is partly because the health insurer has to advertise for members, it has to process claims in a totally different way. And so there's going to be an excess of management costs, overheads. So there's a whole lot of extra money that needs to be found, probably $9 billion that needs to be found somewhere. So either service is going to be reduced, or these private health insurers are going to be so efficient that they save money elsewhere. No evidence that that's going to work. So we think that Medicare Select is probably not a real goer. The other option that's floating around is the so-called hospital benefit schedule, which is sort of the idea that there's a Medicare benefit schedule now, let's have a hospital benefit schedule. And this is based on the idea that this is how we pay public hospitals now. There's this schedule based on so-called diagnosis-related groups, and the Commonwealth payment to the states is essentially based on that. That is, the Commonwealth says we will pay for 45% of the costs of growth at the so-called national efficient price for each diagnosis-related group. For private hospitals, the scheme at the moment is much more complicated. There's this payment through the private health insurance rebate, there's payment from Medicare for medical services in hospitals, and all told, the Commonwealth spends currently about 35% of the cost of private hospital care. About 23% of that is from the private health insurance rebate, about 10-ish% from the Medicare benefit schedule subsidy. So at the moment, the Commonwealth subsidy to private hospitals is around 35%. But so you've got on the one hand the private healthcare subsidy of 35%, the public healthcare subsidy of around 45%. So what happens when we try and meld them together in a hospital benefit schedule? Either the private schedule is going to come up to the hospital schedule, costing the Commonwealth government a whole lot of extra money, or the public schedule is going to go down to the private schedule, meaning there'll be big cuts to state government budgets, or somewhere in between, meaning there'll be some cuts and some increases. So neither of these ideas that we've floated seem to have anything in favour of them. I've referred to them as zombie proposals that ought to be put to death.